This video is going to take you the rest of the way through the respiratory notes. We had stopped on this picture right here, and so we're going to continue on. The next question is, which characteristic helps to reduce the work of breathing? This goes back to the natural elasticity of the lungs. If you remember, the alveoli have elastic fibers that go around them. So here, this guy is blowing air into, this is a set of cow lungs. What I want you to notice is soon he's going to take the air pump tubing out of there, and you'll notice the lungs collapse all on their very own. You don't have to work or make muscles contract in order to do that. They just push the muscle out because of that elasticity. One of the ways that emphysema harms your lungs is they lose that elasticity. So in that first part of this GIF, notice that these lungs, not only does this one not inflate on that side, but they don't recoil like they're supposed to. It makes breathing out harder because you have to work harder to push the air out since you've lost that elasticity. Next, you have compare and contrast the pulmonary circulation and the bronchial circulation. So the pulmonary circulation we talked about back in the circulatory system. The pulmonary trunk splits into the pulmonary arteries, and it takes deoxygenated blood to the lungs, where we're going to be picking up oxygen, dropping off CO2, and then coming back to the pulmonary veins to the heart. So the pulmonary circulation is all about oxygenating the bloodstream and then removing the CO2 from it. That said, the blood that's in the pulmonary circuit doesn't have a lot of nutrients in it, and it has a fair amount of waste in it, and so that would be problematic for the lungs. And so we also have a bronchial circulation that we hadn't mentioned before. Bronchial circulation supplies blood that is not only oxygen rich and carbon dioxide poor, so it's good for the lungs, it also is nutrient rich and it doesn't have a lot of waste in it, so it can pick up waste from the lungs as well. So the bronchial circulation serves the needs of the lungs versus the pulmonary circulation serves the needs of the rest of the body. What is the function of pleural fluid? So it does help reduce friction, like all the serous fluids are going to do, but more importantly for the lungs, because there's a very thin film of it between the parietal and visceral pleura, it creates this negative pressure between the two pleural membranes, and that negative pressure is what's going to help suck the lungs up against the chest wall so that your lungs don't collapse. And so it also helps to keep the lungs up against the chest wall, because there's no ligaments, there's no connective tissue. The only thing that's holding your lungs up against that wall is the negative pressure that's created by that pleural fluid and the surface tension of that pleural fluid. Next up, pleurisy. It's inflammation of the pleural membrane. Just like any other inflammation, when it happens, it tends to secrete an excess of fluid. That's problematic here in the lungs because we need a little bit of fluid to create that negative pressure. If we get a lot of fluid in there, it can create a pleural effusion, which is a buildup of fluid in that area, and then that can cause a collapsed lung. If the pleurisy results from a bacterial infection, we treat it with antibiotics. If it's viral, you kind of just have to suck it up and wait for it to go away. For pleural effusion, they may or may not insert a chest tube. It just kind of depends on how bad it is, but the chest tube would drain out the excess fluid if it was in there. Let's see, that's just another video of that. So, respiratory membrane, okay. Pulmonary ventilation, it's just breathing. Inspiration is breathing in, expiration is breathing out. There are going to be three pressures that matter in relation to ventilation. Atmospheric pressure is the pressure in the air that is around you. If you're at sea level, it's about 760 millimeters of mercury. We're a little bit higher than that, so the pressure is very slightly lower than that, but that's not really going to matter for us. If you go up at altitude to more than 5,000 feet, then that atmospheric pressure gets to be low enough that there can be problems, but we'll talk about that more later on. Next up, the intrapulmonary pressure is the pressure of the air inside the lungs. This is what is going to change depending on whether you're breathing out or breathing in. So this pressure rises and falls depending on muscle contraction and elastic tissue in the lungs. Intrapleural pressure is the pressure of that surface tension that the water was creating in the pleural fluid. It has to be negative pressure to keep the lungs up against the chest wall. If this pressure ever equalizes with intrapulmonary pressure, horrible things happen to you. And so this pressure should always be less than intrapulmonary. One of the things that's kind of important about this that your book mentions is intrapleural pressure. It's always described as being a negative pressure, and it's negative as compared to intrapulmonary. It's not a true negative pressure though. It's just where this might be 760, this is 756. It's lower than intrapulmonary pressure at all times. This picture describes all of those pressures. So atmospheric pressure is again at sea level, 760 millimeters of mercury. Intrapulmonary pressure, when you contract the diaphragm, that actually decreases that pressure so that when this drops, atmospheric pressure would be higher and you would suck air in. When the diaphragm relaxes, it bulges back up and that creates a higher pressure than atmospheric pressure, so you would blow air out. Intrapleural pressure, again, must stay less than intrapulmonary pressure at all times to keep those lungs up against the chest wall. Two factors that are trying to collapse the lungs. First off, we've got all that elastic tissue that's trying to squeeze the alveoli into their smaller possible shape. That's trying to collapse the lungs. Second, we talked about surfactant earlier. That reduced the surface tension of the water that keeps the respiratory membrane moist. Surfactant is reducing that surface tension, but that surface tension inside the lungs is trying to collapse the lungs. So I'm going to come back to this for just a second. The surface tension inside the lungs can draw the alveoli up to a smaller shape and try to collapse the lungs. So we want surfactant in here to reduce that surface tension, but we do not want surfactant out here because we want surface tension between the parietal and the visceral pleura. That surface tension is what helps to create this negative pressure. So in different places, you either do want surface tension or you do not want surface tension. But surface tension plays a big role in keeping those lungs where they're supposed to be. Which pressure should be the lowest? Intrapleural. What happens if it equalizes? We collapse a lung. The fancy word for that is atelectasis. Pneumothorax. So this is, in the military, they call it a sucking chest wound. And the reason it's called that is when you think back, the intrapleural pressure is negative relative to all the other pressures. If your parietal pleura gets breached, what's going to happen is that negative pressure is going to suck in whatever is directly outside of that, whether it's blood because you've been stabbed or it's air. But that's going to suck whatever is in there out, into the intrapleural space. This is going to end up resulting in a collapsed lung. So the story behind this picture was this was a motor vehicle versus a brick mailbox at highway speeds. This is her breast, which I know it's hard to tell because she's very mangled in this picture. But notice that the medic is actually inserting his hand into this hole. That's because that hole has breached the parietal pleura. And so all of the blood from this tissue trauma plus atmospheric air is getting sucked in through that hole. And that's going to make her lungs collapse inside of there. So he's trying to plug that hole to prevent the lung from collapsing and preventing blood from getting into that intrapleural space as well. Next up, which muscles are considered inspiratory muscles? So there's two prime movers. The diaphragm, which when it contracts, it pulls down. What that does is it increases the volume in the chest wall. Then you have the external intercostal muscles. When they contract, they pull the ribs up and out, so they make your chest cavity deeper. That also increases the volume, so it decreases the pressure. So both of those two muscles contract at the same time to make your rib cage wider, deeper, and taller, so that you increase the volume and decrease the pressure, and air always is going to go into a lower pressure place, and so that helps you breathe in. So the act of breathing in is an active process because you have to contract the muscles in order to do that. You can use accessory muscles to help you breathe in more deeply or more forcefully. The story that I usually give along with this is back when my son was 2, he had the worst asthma attack of his life. When you first have an asthma attack, you get a characteristic wheeze as the air is trying to squeeze through constricted air spaces. I thought he had been getting better because he stopped wheezing, when in actuality what had happened was his airway had constricted so much the air wasn't moving through it at all, and so he wasn't getting air to the alveoli of his lungs. If I had known what I know now, I would have known to look for accessory muscles, which some of your accessory muscles are the sternocleidomastoids. I don't know if you remember those names from AMP1. If you see a person using these muscles to breathe when they're just sitting in a chair not doing anything, it means they are working harder to breathe. And that is problematic because it exhausts you to the point where you can't keep doing it, and then you die just because of the workload of breathing. So accessory muscles can help you if you're working out or something, but if you're just sitting there and you're using those, it's really going to wear you out. Next up, I have a little video to kind of show you how asthma can impact things. Oh, no, not asthma, sorry. I was thinking about a different video. This baby has respiratory syncytial virus, or RSV. It causes the stridor cough that you're going to see here in this one. But I'm showing you this video because you're going to notice, first off, a wheeze, but second, you're also going to see those accessory muscles that come in for breathing. notice the abdominals or other sets of accessory muscles that can come in to help you breathe. There is somebody caring for this child in here, so don't think it was just the parents ignoring them. This child had just had a breathing treatment, so it wasn't quite time for another one. But you can see the baby working harder to breathe because of the RSV that they have. All right. Next up, what must you do to breathe out passively? Really, you just relax the muscles you had just contracted, and then that natural elasticity we have been talking about is going to help you squeeze the air out. You can breathe out in excess of a natural quiet breath. That's called forced expiration. So the example that I'm giving you here is like you're trying to blow up a balloon. You're going to get your abdominal muscles involved in that to help you blow out more forcefully. So asthma. The problem with asthma is a twofold problem. One, your immune system causes inflammation to the airway. That makes the lumen of the bronchioles smaller, so you're moving less air in and out of the lungs. Second, remember we talked about this smooth muscle? Well, this smooth muscle can constrict, and that can also decrease the size of the lumen, and that's called bronchoconstriction when that happens. In addition to that, we usually have an excess of mucus that's being produced, and that also makes breathing a little bit more difficult. And so now, this is going to be my video of the asthmatic person showing you what that looks like.
Year-old Chris is having a severe asthma attack. His immune system has made what could be a fatal mistake and is shutting down his airways. Without help from the medical team, Chris's body may shut down completely. I'm not going to die. I'm not going to die. You'll be okay. The breathing tubes in Chris's chest are squeezing tightly shut and filling with sticky mucus, blocking his vital oxygen supply. If he's not treated soon, he will die.
This is a really life-threatening episode of asthma. Asthma is pretty common in our community, and most of the time it's not this life-threatening, but this one is quite serious.
They end up treating him with the standard treatment, which is essentially we give some derivative of epinephrine like albuterol, sambuterol, whatever, something buterol. That is a bronchodilator that relaxes the muscle again to help open the airway. And then we also give steroids to help reduce the inflammation that goes along with that. He ends up being fine. But one of the things I want you to notice is look how high his shoulders are. And again, he's using his accessory muscles to help him breathe. You could also see as he was going that he was using his abdominal muscles to help him breathe. And I don't know if you could hear it very well, but he was also wheezing during that. And so that's asthma and how asthma ends up affecting the airway. Now, infant respiratory distress. Because the lungs are the last organ to end up developing to full term in a baby, if a child is born prematurely, it means their lungs weren't finished developing yet. Specifically, those type 2 cells that we had mentioned, the green fluffy ones, don't make surfactant, and as a result they can't reduce the surface tension of water that's inside an alveolus. As a result, that water draws up into a smaller droplet and it collapses the alveoli. So essentially every time a premature baby breathes out, their lungs collapse after that breath because of that surface tension drawing these all shut. So that is why, especially in the past, there's newer treatment options so that not all premature babies need this, but we would have to put them on ventilators to help keep their lungs inflated in between each one of their breaths. Next up, lung compliance. If a lung is compliant, it means it's nice and soft and squishy, it's elastic like it's supposed to be, it's producing surfactant like it's supposed to. Factors that can mess around with that, if you get chronic inflammation that can result from infection that has lasted long term like tuberculosis, or you have inflammation because of some type of autoimmune disease, if you don't make surfactant like you're supposed to, if you smoke, that dramatically messes around with your lung compliance for a couple of different reasons, and then as you get older your lung compliance does just decrease. After that you have this chart right here. You were supposed to do spirometry in lab. Hopefully we'll get to go back to school so you'll be able to do this. But spirometry measures how well your lungs are actually able to pass air in and out. The device that measures this is called a spirometer. When you breathe into a spirometer that's actually hooked up to a computer, it creates a graph. So when you're just breathing naturally, passively, you get what's known as tidal volume. And for both men and women, tidal volume ends up being about 500 milliliters of air that's getting passed. You can breathe in excess of normal tidal volume. This would be you taking a big, deep breath. That is in excess of tidal volume is called inspiratory reserve volume. You can also blow out air in excess of a normal quiet expiration. That's called your expiratory reserve volume. You do have to keep some air inside of your lungs so that they don't collapse. That's the residual volume off down here at the bottom. So tidal volume, inspiratory reserve, expiratory reserve, tidal volume. This doesn't change unless your lungs collapse. From the volumes, you can start to get capacities. Capacities add up multiple volumes to tell you a little bit more about your lungs. So inspiratory capacity is tidal volume plus inspiratory reserve. Functional residual capacity is expiratory reserve plus your residual volume. Vital capacity, this one is very important. I mean, it even has the word vital in it for life. Vital capacity is all of the air that you can exchange with the outside world. So it's tidal volume plus inspiratory reserve plus expiratory reserve. Pulmonologists test vital capacity all the time in something called forced vital capacity, where they ask you to breathe in deeply and then blow out as much air as you can. And then total lung capacity is exactly that. It's all the air that keeps your lungs inflated and the air that you can exchange with the outside world. This picture, that is an older version of it, gets you that same information, but it shows you how all those things get added together to make the various capacities. So under explain and compare the various lung volumes and capacities, this is a decent table to kind of help you do that. Next up, you have dead space. Dead space is areas in the respiratory system that don't participate in gas exchange. So it is all the conducting zone stuff that we had mentioned earlier, like the larynx, the pharynx, the nasal cavities, and all that stuff. But it also includes any sort of dead spots that you have in the lungs, either due to infection or mucus accumulation, or you killed something off because you've got lung cancer or whatever. But if these weren't participating in gas exchange, this would add to your dead space. So the more lung damage you have, the more dead space you have, which means the less gas you can exchange with the outside world. So spirometers have different levels that you can use. If you have asthma or COPD, they give you one that's like this. There's usually like a little plate or a little ball that's inside of there, and they want you to blow into it so that you can hover that ball at a specific level for a longer period of time. So this not only measures your lung capacities, it can also be an exercise tool to help you increase those volumes over time. This is more what you guys would be using in lab. So you blow into a device that's hooked up to the computer, and then the computer creates that graph that we were looking at just a second ago. Now, forced vital capacity. This was something that we were going to do in class and then measure. I'll make a separate video of me doing that a little bit later on. But to measure forced vital capacity, what you do is you ask a person to take a big, deep breath in, like they were going to try to inflate a balloon in one breath, and then blow it out all at one time. That tells you the total amount of exchangeable air that the person has, and it's a pretty good measure of how healthy the lungs are. And so ideally you want that number to be as high as possible, because the lower it is, the less air you're exchanging with the outside world. Okay. From there, the book starts to get into some physics that relates to pressure, and we're not going to talk about all of that physics because y'all don't have to take physics for the most part. The couple that matter for us. Dalton's law of partial pressure basically comes back to the fact that the air around you is not a pure gas. It is a mixture of several different gases. These are the top 4 that are going to matter for us. Most of the air around you is actually nitrogen, which doesn't matter for you. You can't really absorb this into the body very well. You don't need it in the body in this form, but that is what most of the air is. Oxygen's about 21% of the air around you, and carbon dioxide is less than 1%. The water, it depends on the humidity level in the air around you, but that is a factor as well. So here's the thing. Since oxygen is only 21-ish% of the total mixture of gas that is around you, and atmospheric pressure at sea level is 760 millimeters of mercury, if you take that 760 and multiply it by the percentage that oxygen actually makes up in that mixture, it gets you the partial pressure of that gas that is part of the total pressure of the atmosphere. So where this was atmospheric pressure, oxygen is only making up 159 millimeters of mercury out of that total. Carbon dioxide is only making up 0.3 millimeters of mercury out of that total. Partial pressure is what's going to dictate which gas is moving in which direction. And so this is going to help you understand external respiration and internal respiration. Excuse me. You don't have to memorize any of the values that are up here, but I'm a person who likes hard, fast numbers because it shows you exactly what's going on. What you need to remember is the gases are always going to move from an area of high partial pressure to an area of low partial pressure. So notice that the air outside of you has the highest amount of partial pressure of oxygen out of any of the numbers that you have anywhere on this picture. So since this is the highest, oxygen is going to move from inspired air down through here. So then it's going to go into the alveoli. From the alveoli, it's going to move into the capillaries. From the capillaries, it's going to travel around through the circulatory system where it's going to be dropped off in the tissues because your tissues has the lowest amount of oxygen that's available to it. So that's why the oxygen moves from the outside air into your lungs, into your blood, into your tissues. It's because that's its partial pressure gradient. By contrast, since your cells are constantly producing carbon dioxide, the partial pressure of carbon dioxide is highest in your tissue cells. It's lower in the bloodstream, so the CO2 is going to diffuse into the bloodstream, travel around through these veins and then the pulmonary arteries, and then be dropped off in the alveoli, which has a lower partial pressure than both here and in the bloodstream. And then it's going to get expired or breathed out because the pressure in the atmosphere outside of you is even lower than the pressure that it was inside the lungs, so you're going to breathe that carbon dioxide out. So this explains why each gas moves in a separate direction. It's because they each have their own partial pressure, and this also just shows you why it goes from the bloodstream to the tissues and from the lungs to the bloodstream, in the case of oxygen anyway. So, just like with everything else, you can't have too much of a good thing. You can have too much oxygen. You can really only do this if you're breathing in pure oxygen. So like if they have you in a hyperbaric chamber with pure oxygen, that can do this. If you're scuba diving with pure oxygen, which is not the normal way you scuba dive, usually your scuba tank is filled with a mixture of air. But if you are breathing pure oxygen, that can cause oxygen toxicity. The symptoms for this basically mimic drunkenness, up to the point that afterwards you die. And so oxygen toxicity is problematic for people who are breathing in enriched air that is enriched with higher levels of oxygen than normal. Next, oxygen transport we talked about back in the blood chapter, so I'm going to blow past that. Hypoxia we had already talked about back during the blood chapter as well. You're not carrying oxygen very well. Just like with anemia, there's different types of hypoxia. You can have anemic hypoxia where your blood's not transporting enough oxygen. So that could be any of your forms of anemia, from sickle cell anemia to iron deficiency anemia. You're not transporting the oxygen to the tissues, which means the tissues aren't getting the oxygen that they need. Ischemic hypoxia means that blood is not getting to a specific place in your body. Like there's plenty of oxygen in the blood, but the blood's not going everywhere. So this can happen if you have a clot that gets stuck, if you've had an aneurysm that has ruptured, if you fell asleep on a body part and you smushed the blood vessels in there so that you weren't allowing the blood to get someplace, that can happen there too. If this is prolonged, this is what leads to strokes and heart attacks, and so this needs to be dealt with. If it's a clot, that clot needs to be removed somehow. Histotoxic means there's plenty of oxygen in the air, there's plenty of oxygen in your blood, and your blood's getting everywhere, but your cells aren't actually able to use the oxygen like they're supposed to. So the story that I usually give that goes along with this relates back to cows. So in our area, we have this grass that's called Johnson grass. After a rain, Johnson grass accumulates something called prussic acid in the cells. Well, prussic acid is a precursor to cyanide. So if you release cows onto a field just after a rain, the whole herd can die if they eat the Johnson grass, because essentially you poison them with cyanide in the Johnson grass. And what cyanide does is it prevents you from using the oxygen in something called the electron transport chain, which is why you need the oxygen to begin with. And so you die because you can't make ATP because you couldn't use the oxygen like you were supposed to. That's how a lot of different poisons kill you. This is just a natural example that I kind of wanted to give you. Now, carbon monoxide poisoning is an example of another type of hypoxia called hypoxemic hypoxia. This is specific to the arteries having less oxygen in them than they're supposed to. Specifically because of something called ventilation perfusion coupling, which is your respiratory rate and your blood perfusion get matched up so that you're picking up all the oxygen that you're supposed to. The problem with carbon monoxide poisoning is carbon monoxide binds to your hemoglobin more strongly, more forcefully than your oxygen does. So even though there's oxygen in the air, you're not perfusing it like you're supposed to because the carbon monoxide stole its spot on the hemoglobin. The symptoms that start with carbon monoxide poisoning are usually headache, you feel tired, your face might flush. What happens is people, because they're tired and they have a headache, they think, oh, I'll go take a nap and I'll feel better afterwards. And the issue is you don't have oxygen, so you don't ever wake up from that nap. You just die. If you have any gas-burning appliances in your home, whether it's your water heater or your furnace, you need to make sure you have a carbon monoxide detector in your house, because otherwise you don't know the carbon monoxide is there. It's colorless, it's odorless. You just don't know that it's a problem until people in your family have started to die. And so please get the carbon monoxide detector if you have those sorts of appliances in your home. Next, carbon dioxide transport. We didn't really talk about this back in the blood chapter. We were focusing more on the oxygen. You need to know this equation up here. Whenever carbon dioxide gets into your bloodstream, the plasma has mostly water in it. So when carbon dioxide mixes with water, it forms carbonic acid, which is this little guy right here. This carbonic acid is going to be very important for what's happening to your blood's pH, which is going to play a major role in how you regulate how fast or how slowly you breathe. So that carbonic acid matters. But here's the other problem. Carbonic acid is very unstable. It dissociates into hydrogen ion and then bicarbonate ion, which is HCO3 is a negative bicarbonate ion off over there. So how does the carbon dioxide get transported? Well, some of it does just dissolve in the plasma, like in this step up over here. So you have some CO2 just traveling around in your plasma. Some of it does bind to the hemoglobin, which is what this equation, this equation is trying to show you right here. It is not competing with oxygen for a binding site. It binds to the globin part of hemoglobin, not to the iron and the heme of the hemoglobin. But most of it is actually traveling around in the blood as this bicarbonate ion. So most of your carbon dioxide isn't actually transported as carbon dioxide. It's transported as this bicarbonate ion up there. This bicarb is also going to play a role in regulating your blood's pH. We'll talk about that in the kidney chapter later on. Which two portions of the brain help control your respiratory rate? The medulla has ultimate control. Your pons does play a role in helping to smooth the transition between breathing in and breathing out. Apnea is just a normal respiratory rate for an average adult. Your book says it should be between 12 and 18, but most doctors consider 12 to 20 to be a normal respiratory rate. Chemoreceptors help you regulate how fast or how slow you are breathing at any given time. Chemoreceptors detect a whole bunch of different things. I know most of you probably think it's easiest to measure oxygen levels, and your body does measure oxygen levels, but more importantly, your body measures carbon dioxide levels and then your blood pH. And then those two things play a major role in helping you to speed up or slow down your respiratory rate depending on what's going on. Oxygen levels are tertiary because as long as you're regulating carbon dioxide and pH, your oxygen should be okay. So these two things matter more for controlling your respiratory rate. We're going to do an activity for that later on too. Hypercapnia means that you have elevated levels of carbon dioxide in your bloodstream. This can happen if you hold your breath. The CO2 builds up and so your CO2 levels increase. This also happens in people who have COPD or asthma where they have difficulty breathing out. They develop hypercapnia because the CO2 ends up trapped in their system. The other problem that goes along with this is, if you remember that formula for a second ago, when CO2 levels build up, that means your carbonic acid levels are going to build up. So you become more acidic in your bloodstream when you become hypercapnic. So hypercapnia also leads to respiratory acidosis, which is an increase in the acidity level in your blood, which means your pH drops, because remember, pH less than 7 is an acid level. Hyperventilation means you're breathing too fast because you're freaked out. This is why they have you breathe into a plastic bag. If you breathe out too fast due to hyperventilation, you actually raise your pH and you become more basic, and that's not okay either. That leads to this, which we're going to talk about in a second. So by having you breathe into a bag, whether it's a paper bag or it's an actually expensive medical bag off down here, you're rebreathing in your CO2 so that you can keep your pH where your pH is supposed to be. So hypocapnia is the problem that can develop during hyperventilation. This means that you have lower levels of carbon dioxide because you flushed it out too fast. And again, this does play around with your blood's pH, and so it's not okay to do this. If you develop hypocapnia, your brain's going to make you pass out so that you can accumulate CO2 in the body faster. Apnea means that you stop breathing. For this one, I have a video that I may have showed you last semester. I don't remember. The individual in this video has sleep apnea. I'm going to start playing the video. I'm going to leave this timer going. What I want you to do is try to count this person's respiratory rate. All right, so we counted for a full minute there. I wish you could talk to me and tell me how many you counted, but what I want you to notice is for like the first 30 seconds, he didn't breathe at all. That's apnea. His wife was taking this video because he didn't think he had a problem and she kept trying to tell him he wasn't breathing while he was sleeping. For that full minute, he took 6 breaths, which again, that is not eupnea. That is not a normal respiratory rate. And so that is what sleep apnea looks like. Now, going back to this picture, SIDS is sudden infant death syndrome. It's something that all, especially new moms, freak out about because we're afraid our baby is just going to be dead the next time we go into the room. One of the things that leads to SIDS is the baby stops breathing while they're sleeping. If a family has had a history of SIDS, what you can do is buy this little, well, or get it from a hospital, get this apnea belt, and what it does is it measures essentially the respiratory rate of the baby. If the baby stops sleeping, an alarm sounds off over here, so you can come in and very gently sort of shake the baby. Don't shake the baby hard, but you shake them, try to wake them up a little bit, try to get them breathing again, and if they need it, you can start doing mouth breaths for them so that they get their air filled back up into their lungs. Hyperpnea. This is different from hyperventilation. So hyperventilation, you were breathing fast just because you were emotional. Here, you're breathing fast because you need to. You're running from a hippo, like in this picture. Or you're running on a treadmill. If you're working out, you're supposed to increase your respiratory rate because you're using oxygen faster and you're making CO2 faster, and you're going to have to clear that from the body. So here's the problem with altitude. I mentioned that at sea level, the pressure of air is 760 millimeters of mercury. If you get over 5,000 feet, you don't have that same pressure. The pressure actually decreases. Not only that, but the amount of oxygen in that air decreases. So even if you're still breathing your 500 milliliters of air that you're supposed to for tidal volume, you're not picking up the same amount of oxygen that you would have if you were at sea level. So if you were to go travel to the mountains right now, the basic symptoms that you get at first are you get a headache. Again, you get kind of tired and you feel blah. You might kind of feel almost fluish when you get high altitude sickness. If you stay at altitude for an extended period of time, your body will acclimate to it eventually, usually by your kidneys will produce more EPO. That will help you elevate your red blood cell count. People that live at altitude for extended periods of time, they have their own special adaptations that help them live at altitude. It's why people in Tibet can help other people get up and down. Oh my God, I've forgotten the name of that mountain. That is so sad. Like, it was just in my head. It's not Kilimanjaro. Himalayas. The one that's in the Himalayas that I have completely forgotten the name of right now, and it's probably up here. There we go. Mount Everest. It's why Sherpas can get people up and down. They're used to that altitude. They have adaptations to help them deal with the fact that there's less oxygen available to them up there. Versus if you were to try that, you would probably need oxygen supplementation because there's less oxygen available to you. Next up. COPD is chronic obstructive pulmonary disease. You have, what are the 4 symptoms or features that go along with that? So by and large, most people that get COPD have a history of smoking. However, it is very important that you understand there are people who have genetic links to it who may have never smoked a day in their life and they still get it because their genes essentially told them that they should get it. And so don't assume that everybody with COPD smoked, because there are people out there who didn't. Dyspnea is just the fancy word for they have difficulty breathing. Usually that's described as shortness of breath. They will cough frequently because that mucociliary escalator is broken, and that's the only way they can clear the mucus from their lungs. And as a result of that, they tend to get infections like pneumonia more often. And then this is actually a bunch of things, but hypoventilation, they're not breathing with the same respiratory rate that they're supposed to, and they're not doing gas exchange like they're supposed to. CO2 tends to accumulate because they have problems breathing out, and so they develop respiratory acidosis. And then because they aren't doing the electron transport chain very well, they also get hypoxemia, where they're not able to use their oxygen appropriately and transport it appropriately. The two main types of COPD are emphysema and then chronic bronchitis. Your book has this picture to kind of show you what's going on with each one of those. So basically both of these often happen at the same time, but sometimes you have a person that gets one form and not the other. This is really a problem more with the conducting zone. So your bronchi and your trachea are problematic. Your cilia has been destroyed. As a result, you're not clearing the mucus, so you're coughing. You'll have spasms in your bronchi, and then you'll get edema that goes along with that. On the flip side, emphysema is a lung problem, not an airway problem. So here you lose your elasticity, and so breathing out becomes more difficult for you. That's basically what's happening during COPD. Now, asthma we already talked about. I showed you a video for it earlier. Now I'm really just adding the treatments for asthma. So you use steroids. Pulmicort is one brand of steroid. Advair has a steroid in it. Prednisone is one that they can inject you with or have you take orally. All of those reduce the inflammation and some of the mucus production that happens. Bronchodilators are what you have in rescue inhalers. Those help to relax the smooth muscle that had been causing bronchoconstriction. So bronchodilators counteract that. Very often they're also given, this is an anti-leukotriene, which is another thing that helps to reduce the inflammation. They'll also be given a lot of times allergy meds like antihistamines like Claritin or Zyrtec to help reduce some of that inflammation as well. A little weird side note. So there's a list of meds that comes out periodically that are like the top 10 meds that a doctor wouldn't take for themselves, and Advair is usually towards the very top of that list. Advair has steroids in it to help reduce the amount of inflammation that goes in there, and it also has a bronchodilator. The problem with it is it actually does not decrease the chance that you die of an asthma-related event. And so even though it's one of the most prescribed asthma drugs that are out there, most doctors would not take it for their asthma if they had asthma themselves. So just keep that in mind. This is a device that is used to treat both COPD and asthma and sometimes some other problems as well. This is not a spirometer. This is a nebulizer. It's essentially a little air pump. You hook the tubing up to it, and then you hook it up to, there's different kinds of mouthpieces. This is for a person who can hold this into their mouth. You can also do face masks that aerosolize it. You put whatever the aerosolized medicine is that's going to be in here. It can be albuterol or it can be a steroid. And then this just aerosolizes it so that you're breathing in the medicine and it gets directly into the lungs. So this is something that if you work in medicine for any length of time, guarantee you're going to end up nebulizing somebody. It helps to just get that medicine directly to the lungs where it's needed. Other problems. So tuberculosis is a bacterial infection. You do need to know that there's two stages of TB. Latent TB, a person doesn't even know they have it. This is why anytime you work in the medical industry, you have to go and take a skin test. It's because you might have tuberculosis and not know you have tuberculosis. So you go, they poke you usually someplace on a forearm, and then you come back later and they check to see whether or not where they poked you got really super red and puffy. If it did, it might mean you have tuberculosis, but that test does give a lot of false positives. So the next step, if you did pop positive on that skin test, would be to go do a chest x-ray to find out whether or not you have nodules. This is a micrograph of a nodule. You'd be able to see that on an x-ray as a splotch within the lungs. If you have that, plus you popped positive, you have tuberculosis, and they would put you on antibiotics to try to get the infection to go away. In contrast to latent, you have active TB, where the person is coughing all the time, they're losing weight. I did go ahead and put this in here. If you look up like U.S. history, you'll find a lot of our presidents died of tuberculosis prior to the advent of antibiotics. The issue with tuberculosis is this isn't like you take a Z-Pack for a week and yay, you go skipping off into the forest. This bacteria is different from most. It's not gram-positive or negative like E. coli or Salmonella. It's what's known as acid-fast. Because of a quirk in its cell wall, it's difficult to treat. So you end up having to be on a combination of antibiotics, not just one, but 2 or 3 antibiotics, and you have to take them for 6 to 12 months depending on basically how resistant your tuberculosis infection is to those particular treatments. You're not supposed to go out in public when you have active TB. They can quarantine you against your will if you're not following medical advice. They can even do supervised meds where a nurse comes to your house to ensure you're taking your antibiotics and you're complying with your medical treatment. Tuberculosis is not a joke. It is crazy contagious, and it's fatal if not treated, and so it's not something to play around with. Lung cancer is exactly what it sounds like. I did want to show you that the death rates for lung cancer have been decreasing due to especially increases in healthcare and new treatment options that happen for that. But that said, notice that's still not awesome. We're down to like a 40-50% fatality rate when it comes to the death rate of a person diagnosed with lung cancer. While smoking is implicated in the majority of cases, again, just like with COPD, some people just have bad genes and they get lung cancer because their genes increase their risk for that. People who work in places that are crazy polluted, like coal mines, some places where they do a bunch of welding, if they don't wear proper respiratory gear, they can get it from that as well. People who work in concrete factories are at higher risk for this because they can inhale the particulate matter that goes into that concrete. Cystic fibrosis is a genetic condition. Usually what happens is two parents who didn't know that they were carriers get married and have some babies, and there's a 25% chance that they produce a child who has cystic fibrosis. Cystic fibrosis super sucks because the person can kind of be healthy, but they're still not allowed to go out and like have a life and play in public because they are very susceptible to infections. It's because they produce this really thick mucus that it's very difficult to get out of the airways. We do things like chest clapping to help clear that out. There are new treatments on the horizon for this, including gene therapy and CRISPR-Cas, but right now the prognosis for cystic fibrosis is not good, where most people end up dying in their early 20s. Normal respiratory rates. Infants breathe really fast, somewhere between 40 to 80 breaths per minute. 5-year-old, it starts to slow down, but it's still higher than an average adult. They're usually breathing about 25 times a minute. We already talked about eupnea for the adult, 12 to 20, someplace in there. Again, your book does say 12 to 18. After that, because your lung compliance decreases, it starts to increase your respiratory rate again. So a geriatric patient is usually going to be somewhere between 20 to 30 breaths per minute. Okay. After this, I'm going to make a video about holding your breath and controlling your respiratory rate, and then forced vital capacity. Once we do that, you're going to be able to complete the quiz that's at the back of the notes. Once you complete that quiz, I might have to edit it because of that forced vital capacity, or I'll just give you some numbers from past classes and you can graph the past classes. But you're going to scan that or take clear pictures that I can see of that quiz, and then you're going to upload that into Schoology for your quiz grade.